the known differences in child obstetrics, is that paid forward into known disparities in prematurity? And does that become known, like ongoing disparities in pediatric respiratory disease? And is one manifestation of that disparities in ARDS presentation, severity, management, and outcomes?
Welcome back to PedsScript. I'm Zach Hodges, a Peds ICU fellow at UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
So today's part 3 of our 3-part episode on pediatric ARDS.
Yes, and today we are talking with Dr. Yehya about adjunct care for refractory ARDS, the healthcare disparities surrounding ARDS, and then really the cutting-edge research of what happens to these patients after they're discharged from a prolonged respiratory admission.
So I know during our conversation, it was really obvious that Dr. Yehya is an excellent clinician, but also keeps his hands on the pulse of the research in this area. I really enjoyed hearing his insight into what are the next steps in ARDS research.
Yes, me too. Let's get right to the episode.
But maybe to give you opportunity to at least introduce to us and our listeners how you think about other adjunctive strategies for ARDS, kind of outside the ventilator. I'm thinking about prone positioning, INO, steroids. What do you?
Absolutely. Yeah. So a lot of I think a common trajectory that people take is medications. So that's most commonly neuromuscular blockade and steroids are the two escape routes. Prone positioning, inhaled nitric oxide, other ventilator modes, which we've talked about, and ECMO. I think those are like the broad categories of like escape routes that people think about in terms of this. Neuromuscular blockade has a little bit of data behind it. In like the initial Accurasis trial had a suggestion of improved mortality with neuromuscular blockade. That didn't pan out in the Rose trial. Rose had like some major differences in the patient selection, the actual protocol that made trial interpretation difficult, whether or not Rose more accurately reflected current practice or whether Accurasis had changed practice enough that people were giving neuromuscular blockade to the really desynchronous patients who would benefit from it, so that by the time Rose came around, nobody was comfortable randomizing the ones who are most likely to benefit. I think that's an open question. But certainly neuromuscular blockade exists in the armamentarium of ways to improve ventilator desynchrony in desynchronous patients. And that is thought to potentially improve oxygenation and ventilation and reduce peak pressures and unintentional desynchronous double breaths and unintentionally high pressures that are exposed to the lung by like actually taking away the work of breathing. Neuromuscular blockade also does have the benefit in shock patients of, in theory, like reducing the work of breathing, making it entirely dependent on the ventilator. So you could like reduce the amount of cardiac output that's going to diaphragms and respiratory muscles, and it can go to like more important things like brain or kidney or adrenals or something, right? And so there's the thought that like neuromuscular blockade should be thought of actually as an ARDS adjunct. Corticosteroids are certainly an option as well. There's been a good 30 years of trying steroids for everything in ICU, and ARDS is certainly no exception. The really, really, really crazy high, like room doses of steroids probably are not appropriate. The more reasonable 2 per kilo per day Midori solumedrol doses are still currently used in many institutions. People institute them somewhere between 3 and 14 days after ARDS onset, sometimes earlier in the more severe cases. And the Dex ARDS trial and with COVID, and the comfort people have had with dexamethasone as an alternative corticosteroid to use in inflammatory lung injury has also reintroduced the idea of dexamethasone instead of solumedrol. The dexamethasone protocols also tend to be shorter, so people are only married to corticosteroids for like 5 to 10 days instead of like 2 to 4 weeks, like they used to with the solumedrol protocols. And so that remains a ARDS, a moderate severe refractory, like, you know, kind of dragging on ARDS, like that corticosteroids remain in the armamentarium for that. Prone positioning got a lot of attention because the 50% relative risk of mortality improvement seen in Prosiva was unprecedented. Like nobody saw that coming. And it was a very clear signal that if you pick the right patient population correctly and give this targeted therapy, you may have in fact found a really good bullet that keeps a lot of patients off of more aggressive therapies like ECMO or bad ventilator settings on conventional. And proning makes a lot of sense as to why it should work. So two broad mechanisms have been invoked for why proning works. One is that you improve VQ matching by, like we talked earlier about how like a lot of your disease lung is in the back, but all your ventilation is occurring anteriorly, but all your perfusion is posterior. And by prone positioning, okay, like what you do is you don't have quite as much anterior atelectasis because your heart and your sternum can buoy the anterior lung field. So in the prone position, you don't get quite as much collapse as you would in the supine position, where like you have all your abdominal contents, which are crushing a lot of your posterior lung regions. So in fact, in prone positioning, you get to open up all those posterior lung regions, and your anterior regions don't become correspondingly quite as crushed because your heart and your sternum can kind of buoy them open a little bit better than your backbone can. So you've improved ventilation perfusion matching. But probably the more important mechanism of prone positioning is that by opening up more lung, you've spread out the amount of lung available for a given tidal volume to be delivered to, so that any individual lung unit is not quite as distended. In other words, you've reduced the driving pressure for the same tidal volume by opening up recruitable lung. Said yet another way, and this is like kind of more how I think about it. When you guys breathe, when people who don't have ARDS are breathing, there's a very smooth, symmetric, fluid-like behavior of your lung, where like your lungs kind of go in and out relatively smoothly, relatively symmetrically. That's not what's happening in ARDS. ARDS is heterogeneous lung disease, where like the disease portions are rocks. They're like, they don't move. And the portions that are attached to the rock are not, it's not a homogeneously inflating balloon that's like getting over distended. It's a balloon that's taped to a rock that feels the stress, the added stress of being stuck to this, tethered to this thing which won't move, which is additional stress that's being applied to that lung unit. So it's a mix of liquid and solid state behavior. And what you're doing by prone positioning, by opening up more lung, is you're moving the lung back toward homogeneity. And that you're moving it a little bit closer toward a more symmetric open and closing as a liquid state behavior that it wants to be. And so that, we're all saying the same thing. These are all different analogies that are essentially getting at the same fundamental concept of like, there is some stress and some strain that mechanical ventilation causes, and we are still trying to find the right surrogate to like identify how to operationalize what that is. But these are all, they're all variations on the same theme. Okay. And like, but the idea that disease lungs are heterogeneous and healthy lungs are homogeneous, that is probably the way I think that prone positioning is working. And I think that there's animal data to kind of bear out. There's human data to bear out that like, that the degree of homogeneity of inflation, deflation, EIT and technologies like that allow you to have real-time monitoring of inflation, deflation across multiple breath cycles are good ways to like try to test those things at the bedside and doing physiologic experiments.
I was just going to say, I think an extension of what you're saying is there's probably certain patients that will benefit from certain of these certain adjunctive therapies. You know, that patient who's really desynchronous with their ventilator, maybe neuromuscular blockade is really what they need to get them over the worst part of their illness. You know, I'm thinking about our COVID patients, pneumonia. So certainly many of them, when they're prone positioned, they seem to oxygenate better. And then steroids, a patient coming in with ARDS from a hyperinflammatory syndrome, if you don't give them steroids, they're probably not ever going to get better. Like a rheumatologic condition.
Exactly.
Maybe to finish off this section, how do you think about using inhaled nitric oxide in your patients?
So we do. There's been a couple of nitric oxide trials. None of them are particularly big or particularly convincing. There's a consistent sense that they improve oxygenation. There's a less consistent sense that they improve ventilator days or mortality. The way nitric is currently recommended for use in PALIC is considered to be used as a bridge to or to prevent ECMO. So as part of the kitchen sink peri-ECMO or pre-ECMO, if it's something which is available to you, you can consider using it. It's an expensive therapy, and its use is restricted sometimes institutionally, sometimes by resource limitation, in different parts of the world, or even in America, depending on like which system you're operating under and whether ARDS is a indicated use of nitric oxide of an expensive, unproven therapy. But it will improve your oxygenation in that like in 2/3 of patients have a positive oxygenation response that's measurable by like an improved PF ratio or like improved SF ratio if you don't have an arterial blood gas. In patients with pulmonary hypertension or with some degree of RV dysfunction, you may reach for it sooner than as a bridge for ECMO. So like a lot of the ex-preemies who don't necessarily endorse a diagnosis of pulmonary hypertension or aren't medicated on sildenafil or anything like that, but who, when they get sick, will in fact have very reactive pulmonary vasculature that cannot handle higher blood flows or like increased cardiac output. Like, I mean, if you have a normal PVR, if pressure equals flow times resistance, and if you have a normal cardiac output and you don't have high RV pressures, but then if you double your cardiac output because you're starting to get tachycardic because of your shock or your sepsis, and now suddenly your RV is under strain because you can't accommodate that increased cardiac output. Now you have pulmonary hypertension, right? So like in some of these, there are some populations that may be prone to PH either because of underdeveloped, developing, or premature lungs that are getting ARDS or some other comorbidity, or frank PH. That's just part of your ARDS. It's a known complication of inflammatory lung injury. It's a known complication of sepsis. There's no reason why like it doesn't also happen in children. And so in some of those patients, if you have some objective evidence, like either a combination of BNP and echoes, then you could consider like reaching for nitric oxide sooner. And it kind of gets at what Zach was saying, that like that the targeting of therapies based on physiology or presumed physiology in the absence of definitive data, like that's probably okay. But what a different way of thinking about that is like, if we really do think that that's how it's working, if we think that's the mechanism of action, then we should have the courage of our convictions and do a trial. We should actually test it for efficacy. And if in the case of nitric oxide, if that's actually how we think it's working, if there's a population that we all agree should get nitric, like you have PH, you should get nitric, okay, then exclude them from your trial. But then like the other ones who like, you know, like who do you think would benefit from it? And then how do you set up a way to study, like, is this therapy efficacious? And then is this therapy going to improve outcome? And then test it. In the case of, you know, desynchronous patients, you come up with like everybody's going to paralyze this patient. There's no equipoise not to paralyze this patient. If you do that, is there still a population in which we should test the efficacy of neuromuscular blockade? And then we should do that. And we should be willing to at least entertain that as a way of moving our field forward and catching up with the adults.
Yeah.
Okay. Like identifying the right therapy for the right patient. Like we think of that as in we're good at doing that by our vague descriptors like dysynchrony or pH, but we're not. We're using those as crutches until we actually can get to a better way to define the population to do a study. And I think we should consider thinking of it that way.
Yeah. If there's no clear established benefit, then we should do a trial.
I would think that we should at least be open to doing a trial.
Well, now that we've moved through our adjuncts, how do you think about deciding to put your patient with refractory ARDS onto ECMO?
Like everything else, risk benefit. So certain diagnoses which have predictable turnarounds and controllable physiology that I think have a high probability of getting control of. And if the risk benefit is I'm going to continue you on PIPs of 50 versus putting you on ECMO, or like I have you on the oscillator and you're on like 80% of FiO2 and we're okay now, but we've been escalating for the last 2 days and I don't want to escalate tomorrow and crash you onto ECMO, so I'm going to electively put you on ECMO right now when I think I have some metastability. Everything ends up being risk benefit. So like so certain diagnoses like asthma, pertussis, RSV that have very high survival rates, irrespective of the mode of supportive care. If I have reached a mode of supportive care that I think is toxic, then I would consider ECMO, because I think that this is a self-limited process that should get better with if I just buy you an X amount of days of time, and that is worth the risk of bleeding, anticoagulation, hardware infection that comes with cannulation. Other diagnoses I wouldn't feel quite so sanguine about. Like if you were a double bone marrow transplant for, you know, a refractory cancer, which is only recently gotten under control, and you look like you're potentially like have a fair amount of endotheliopathy that may make this a very difficult to achieve adequate flow degree of shock, like a vasoplegic patient with very difficult to establish, like, you know, like the level of flow needed to like actually oxygenate and ventilate you. I worry that you wouldn't necessarily be a good ECMO candidate and may be better off by like actually trying to get by with mechanical ventilation, adjuncts, and drugs instead of bypass or partial bypass. And so everything comes down to risk, benefit, and candidate selection. One way, like if you put me on ECMO right now because you were like mad at me or something, like I would probably be okay in a couple days. The lesson from that is that like there's two lessons from that. One is that institutions that do a lot of ECMO get better at ECMO. And so much like you guys were talking about the fact that like that there's a lot of institutional variability in which modalities people reach for. That's true of ECMO as well. But ECMO, just like everything else, you will get better at it as you do more, like surgery, like, like a surgeon who does 50 hernias, their 50th hernia should be better than their first hernia. And so there's an experiential knowledge which is gained from doing a procedure. The other lesson to be gained from this is the exact opposite. That one way to improve your overall survival numbers is to put patients on ECMO who did not need ECMO. Okay? Like if you put people on who would have done fine with a couple days on conventional ventilation, then you can improve your ECMO survival. But because now you've actually started recruiting a lower risk population to a higher risk therapy. And so it's always interesting to kind of see the epidemiology of these things as they change. As people become more comfortable with the technology, there's this period of trying it out on patients who may or may not be great candidates, in both directions. Not great candidates because they're too sick, and not great candidates because it's not clear that they really needed this, And so you always need to be aware of that as you're, I think, reading the literature in this field. So, again, absent good data, and I think Eolia was pretty good data. The adult trial, which demonstrated, the efficacy of ECMO, which had a p-value of, 0.07, but in which had a 30% crossover rate for severe ARDS into ECMO, which would have had a very, very, very significant p-value had those patients not gone on to ECMO in the control arm. I think that was actually fairly convincing that ECMO does work for refractory hypoxemia and hypercarbia. In pediatrics, the risk-benefit ratio is just different. It's just different because we have different mortality rates, we have different cannulation strategies, different institutions will have different degrees of comfort with it. ARDS is 5 times more prevalent in adults. And so even though ECMO was a NICU and then PICU thing, after H1N1, it became an adult thing. And now they're better at it than we are because in the subsequent 15 years after H1N1, they've done more of it than we have because they have 5 times the prevalence of ARDS. So they're actually better at this than we are at this point, right? Because just by pure numbers, they've more than caught up to us. They've exceeded us in many ways just in terms of their experiential knowledge. And so in terms of what that means for pediatric, putting a given pediatric patient on ECMO, absent strong data, then pick your risk and benefit, try to pick your patient correctly, and then decide whether what you're doing right now is better, worse, or same as putting them on ECMO. And I think that's the best you can do.
Wow. Something to watch in the field for sure. Very interesting on both sides there.
So we try to identify disparities on this show and really possibly make any changes after becoming more aware of these type of things. So is there any disparities that you've seen or identified in pediatric ARDS that you can talk about?
Yeah, this is an excellent question, actually. There's probably in 2017, I want to say, we participated in a multi-center, multinational study of pediatric ARDS all over the world. It was the intent of the study was to validate the 2015 PALIC definition. And we found incredible disparities in terms of how different low and middle income countries, which therapies they reach for first versus more developed countries with higher incomes. And so the worldwide burden of pediatric ARDS is not well defined at all. A lot of the vast, vast, vast majority of the data comes from developed countries like North America, a lot of the European high income countries. There's some emerging data from China. There's some emerging data from Thailand and the Philippines and Singapore, but there are huge swaths of massive high morbidity, high burden of disease places where we don't even know what causes ARDS. We don't know what causes ARDS in the Indian subcontinent or Pakistan. We don't know what causes ARDS in a lot of sub-Saharan Africa. We don't know what resources are available. We don't know, in terms of, are people better off with, when it's proning, how many, what is the allocation of, ventilator to per country? Okay. And so the overall burden of what this disease process looks like over the world relative to who's actually dying from it is a huge question mark. Bringing it closer to home, it's not clear that we have even addressed whether different parts of this country, in a developed country, are completely overcoming the intrinsic disparities of having differential levels of healthcare that are often determined at a more local level, like states. Okay, because states and localities have a fair amount of input into how a given hospital is funded or how a patient population in pediatrics it gets their health insurance, and that impacts like what therapies are offered and when patients present to care. And so even though like there's certainly a global disparity, which we have some sense of that exists, and that there's huge gaps in terms of identifying like which patients where are dying of this disease process and what kind of supportive care do they have available to them, and is that why they're dying, and what does their disease process even look like? Are they getting it from the same things that we think that developed country children are suffering from, or is it not? Even within America, I don't think we have a really good sense on how often do patients of different races and different socioeconomic statuses or accesses to healthcare, are they presenting differently? Are they carrying their comorbidities forward, where like the known differences in child obstetrics, is that paid forward into known disparities in prematurity, and does that become known like ongoing disparities in pediatric respiratory disease, and is one manifestation of that disparities in ARDS presentation, severity, management, and outcomes? So like that's a huge question that I worry is just a function of just a perpetual disparity that we all live in because of a fractured healthcare system with a lot of regionality. So both globally and domestically, I think there's a ton of areas to investigate with respect to like, are all the children, who's dying of this and why? Like, and I think that there's a local version of that question as well as an international version of that question.
Maybe a quick follow-up question that kind of goes in line with what you're saying. Say your patient in the ICU survives ARDS.
Yeah.
What are the long-term considerations that we might not be thinking about there in the PICU, like neurodevelopment, things similar to that?
That's a great question. The one of my fellows turned faculty recently is like actually trying to investigate this in a little bit more granular detail. There's a sense that a lot of these children have some degree of like respiratory impairment, and there's kind of a known like bronchiolitis, which turns into like, reactive airway disease and some level of that presentation. But the neurocog stuff is actually very understudied. And like there's investigators in like Colorado. Aline Maddox is a young investigator who's like pioneering this work. She has a K-23 to investigate some of this stuff. And I have a colleague at CHOP who's like investigating some of this stuff also. But a lot of it's like in its infancy. We don't have a good sense as to what happens to these children neurocognitively. In sepsis, which is a parallel disease process, there is an initial worsening with some degree of renormalization by 12 months. And so you get closer to the trajectory you were on. But I don't even know if that doesn't imply a disparity, or excuse me, not a disparity, but a problem, even though it looks like you're back on track. And one of the problems with this is I think about trajectories and the way we think about adult long-term like trajectory, and that's where we extrapolate a lot of pediatric outcome stuff, is thinking about the way the adults do it. But it's just a whole different thing. Adults are decaying. Like adult ICU and adult ARDS happens at a median age of like 60, 65 or something like that. And by then you're kind of on like a decline. And so you get an acute insult and on the background of the natural decline that comes with age. And then you take an acute insult, and how does your body respond to that? And there's a lot of studies which have tried to characterize that epidemiology. But kids are different. Kids should be getting better. Like a 4-year-old becomes a 5-year-old becomes better. Like they can do more things. They're faster. They're smarter. They're like in a higher grade of school. They have higher cognitive function. So getting back to the level of a 4-year-old is not great. And so how does an acute illness, particularly acute respiratory illness, which affects your oxygenation, perfusion to your brain, sedative, paralytic, weird medications, exposures, how does that acute insult happen on the background now of expected improvement? Like that is a huge unknown. And so like I think that's actually like how we need to set up our studies in terms of longitudinally looking at this to be able to answer this. It may not be good enough to get back to where that kid was a year ago. That itself may in fact be like much more problematic than we're giving it credit for. And so how to measure these things, what are the right batteries of tests? And like, like at the end of the day, you want this kid like doing well in school and playing soccer again, right? And you know it when you see it, and being able to like actually turn that into something consistently measurable, and being able to get follow-up clinic amongst a group of people who chose this fellowship in part because we hated clinic. And so being able to figure out a way to like actually get them to actually do this is like a huge lift. But I think it is an important question to do it correctly.
Excellent. Well, thank you so much for the time that you've taken with us today on this supersized episode. I just want to sort of wrap up here at the end. And would you care to give our listeners maybe some of your favorite main take-home points so that they have something to, if there's just a handful of things that when they hang up the episode, they're like, this is what I'm going to come away with. What would you want them to come away with?
Absolutely. So identify the cause of your ARDS, okay? Like try to figure out like what's actually causing it and think of it that way, that is a source you need to control in order to get out of this. The rest of ARDS care management is all just supportive care for the lung to provide good enough oxygenation and ventilation, knowing that everything you do to them from ventilator settings to sedation to drugs is not really thought of as right or wrong, but is more thought of as risk and benefit, and everything comes with a cost. There may be a benefit to what you're going to offer or what you're about to offer. Like it may pay off to like take away their dysynchrony. It may pay off to like improve their oxygenation, but it's going to come at some cost. And to give some thought to your interventions as risk and benefit. Operationally for most patients, okay, try to limit your tidal volumes, try to limit your pressures, try to give them enough PEEP and enough oxygen that you can keep them out of shock, keep them from arresting while you're trying to get that source control. And then for the ones where that isn't working, then start being willing to be more aggressive, always being cognizant of risk and benefit with your more aggressive therapies.
Excellent. Is there anything you want to plug before you go? Any favorite things, any organizations, things you want our listeners to check out?
Oh, yeah, no, that one caught me off guard. Join ATS or SCCM. Like if you're really interested in the academic parts of this stuff and seeing not even just the cutting edge, SCCM and ATS, the American Thoracic Society and the Society of Critical Care Medicine, are probably the two main like critical care professional societies where pediatric and adult ICU have found homes. And they're open to everybody with any degree of clinical to research to bench interest in anything critical care. And so for lung and ARDS things, I would definitely say like, you don't just need to, be somebody who's actively trying to get grants or publish and things like that to be part of this. Sometimes you just want to be around this just to impact the way you think about how you tackle your therapies in a very practical way, in a very like kind of actionable, this is what I would do in this situation, but just giving you a different way of thinking about these things. And sometimes it's nice just to be around other people who like talk and think about this stuff. Okay, even if you're never gonna like necessarily even publish in it, it's good to like join some of those and go to some of those meetings for a few years to get a vibe of what that's like. And it's a fun community. It's PICU's small. It's like there's not that many of us all over, and so after a while you get to see your friends over and over, and that's actually like a really rewarding part of the work.
And thank you for listening to this episode of Pediatrics. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.